Whether it's a 2020 news show or a made-for-TV movie, too often the face of our state is that of a person missing a mouthful of teeth. While this stereotype is unfair, there's little doubt that we do have a serious problem in the Commonwealth of Kentucky. Oral health care is and remains a major health challenge for this state. In 2004, Kentucky led the nation in missing teeth among people age 65 and older. Some 27% of Kentuckians of all ages had lost 6 or more teeth to decay or gum disease, compared to nearly 18% nationwide. Not surprisingly, these problems start at an early age. In 2001, about half of Kentucky's children had decay in their primary teeth. 46.8% of children ages 2, 3, and 4 had untreated problems such as a cavity or a missing tooth. That's more than twice the national average. And nearly 40% of these children had never seen a dentist. Yes, these statistics are real, and they are also unacceptable. Dental problems are preventable. They just have to be made a priority. Today, we're beginning making them a priority with a 3-year initiative that aggressively focuses more than $2 million in state and federal resources on the causes of Kentuckians' poor dental health, especially in our children. More than $1.6 million comes from 3 federal grants obtained by the Kentucky Oral Health Program within the Cabinet for Health and Family Services. One grant is for $877,332, and it's from the Federal Health Resources and Services Administration. A second grant is for $593,978, and it's from the Appalachian Regional Commission. And a third grant is also from the ARC. It's for $148,122. These grants require a state match, and the state is contributing to this initiative services and administrative costs worth over $464,000. We're undertaking a 3-part strategy to improve the access of young patients to dental care and to improve Kentucky's overall dental health picture by tackling the causes of the problems. One of the biggest challenges remains access. There are too few dentists, particularly pediatric dentists. In fact, only 28 of Kentucky's 120 counties are home to a pediatric dentist. In addition, a limited number of dentists accept Medicaid patients, and in many areas, transportation is inadequate. Another challenge is attitude and education. Not enough people truly understand the link between good oral health and overall health. Another challenge, quite simply, are poor habits. We collectively must develop better oral hygiene practices and better nutritional habits. Now, how are we going to do this? The first piece of the puzzle involves increasing the number of Kentucky dentists willing and able to treat patients under 6 years of age. Child patients pose challenges, but unless a dentist is specializing in pediatric dentistry, he or she receives only limited training in providing care to children. The Kentucky Oral Health Program, working with key stakeholders, will develop a curriculum that teaches effective pediatric technique. This technique will be known as the ABCD Initiative, or Access for Babies and Children to Dentistry. Once Kentucky's curriculum is finalized, local practitioners will be assisted through a series of seminars, web-based training modules, and mentors drawn from pediatric dentists in both private and university practices. Providers will receive 2 kinds of incentives. One, a stipend of up to $1,600 to offset the cost of training. And 2, the opportunity to earn up to a year's worth of continuing education credits, an annual requirement for license renewal. The credits will be issued by the Kentucky Board of Dentistry. So that's step one, getting the right training in place and making it available to dentists statewide. The second step involves really focusing on those counties in Appalachia, especially the 40 counties designated as distressed by the ARC, with extra efforts. The chief component here involves creating local coalitions to create and tailor oral health care programs to the specific communities. This recognizes that because problems differ from county to county, what works in one county might not work in another. These coalitions will work with local public health departments and other partners to assess dental health on the community level and to propose and implement solutions. These solutions, for example, might include school-based dental plans or transporting patients to another county for access and services. The coalitions will be eligible for additional grant funding for these programs. They will also be eligible for additional training on how to apply for other grants. We anticipate being able to fund up to 12 such coalitions. A third step, which will happen in year 3, is to buy portable dental equipment that will be made available to ARC distressed counties to increase access and utilization of dental services for both adults and children. This is not a mobile treatment van like we usually envision, but instead the latest portable equipment that can provide a full array of dental services in non-traditional treatment settings like schools, child care facilities, or senior citizen centers. We expect to have at least 2 sets of this equipment initially, with hopes of obtaining more later.